Welcome to our video on pancreatic cancer. Let's get started. Here is our overview slide. We'll be discussing the definition, pathophysiology, risk factors, clinical presentation, diagnosis, and management. Let's start with the definition. Pancreatic cancer is a highly lethal malignancy of the exocrine pancreas. Cancer of the exocrine pancreas typically refers to a ductal adenocarcinoma of the pancreas. Pancreatic cancer can occur in the head, body, or tail of the pancreas. Patients with a tumor in the head of the pancreas may develop an obstructive jaundice. This occurs when there is impaired excretion of bilirubin from the liver to the intestine due to blockage of the biliary and pancreatic ducts from a tumor. Obstructive jaundice also leads to characteristic clay-colored stool. This occurs because the biliary obstruction, which can be secondary to a pancreatic tumor, decreases the amount of bilirubin in the intestines. The decreased bilirubin leads to a decreased amount of stercobilin, which is the product that leads to the brown color of stool. Risk factors include events that lead to chronic inflammation of the pancreas. This includes chronic pancreatitis, smoking, high-fat diets, a family history of pancreatic cancer, and primary sclerosing cholangitis. Pancreatic cancer can present with painless jaundice due to obstruction of the biliary system by a tumor in the head of the pancreas. It may also present with some common symptoms of malignancy, such as weight loss, weakness, loss of energy, and anorexia. While some patients experience painless jaundice, other patients may complain of abdominal or epigastric pain. For this reason, it's important to pay close attention when the characteristics of pain change in a patient with chronic pancreatitis. If the pain changes significantly from their typical abdominal pain, they may need to be evaluated for pancreatic cancer. Patients may also experience tea-colored dark urine and clay-colored stools due to the obstructive jaundice from a tumor. While rare, patients may also experience Trousseau syndrome. This is an unexplained superficial thrombophlebitis that occurs secondary to a hypercoagulable state with pancreatic cancer. Patients may also present with Courvoisier sign. This sign is a painless, palpable right upper quadrant mass present in pancreatic cancer. The mass is actually a non-tender and distended gallbladder secondary to obstruction of the biliary tract. Another sign associated with pancreatic cancer is the Sister Mary Joseph nodule. This is a non-specific periumbilical mass that's associated with gastrointestinal malignancies. There are several labs that can be ordered to help determine a diagnosis of pancreatic cancer. First, a CMP should be ordered to assess aminotransferases, alkaline phosphatase, and bilirubin levels. These labs can help determine if cholestasis is present. Patients should also have a serum lipase level drawn to evaluate for pancreatitis. Urine urobilinogen levels are expected to be decreased in the setting of obstructive jaundice due to pancreatic head tumors. GGT levels can also be drawn in order to evaluate for damage to the liver and bile ducts. CA19-9 is a tumor marker that's associated with pancreatic cancer, but it has a low specificity and is elevated in other malignancies besides pancreatic cancer. The initial imaging for suspected pancreatic cancer is a transabdominal ultrasound, which can detect biliary dilatation and identify the level of obstruction. However, it may be difficult to visualize tumors in the body and tail of the pancreas with ultrasound. If a patient has a mass suspicious for pancreatic cancer on ultrasound, then they'll need to have a CT scan in order to further visualize the mass. Pancreatic tumors in the body or tail of the pancreas may only be visible on CT scan. After the tumor has been visualized, a biopsy will be required for a final diagnosis. Pancreatic cancer has a poor prognosis, but there are several options for treatment to try to extend survival. The first of these is a surgical procedure known as the Whipple procedure. This procedure is also known as a pancreaticoduodenectomy. This extensive surgical procedure removes the pancreas, duodenum, proximal jejunum, distal stomach, gallbladder, and common bile duct. However, if patients have distant metastases or invasion of the superior mesenteric, celiac, or hepatic arteries, they'll not be candidates for surgical intervention. This is due to the fact that in patients with disease limited to the pancreas, the benefits outweigh the risks of a complicated surgery such as the Whipple procedure. However, in patients with extensive disease, the benefits no longer outweigh the risks of this complicated procedure. Patients may require adjuvant chemotherapy in addition to their surgery, or may receive chemotherapy alone as treatment if they're not surgical candidates. All right, let's finish up with a question. A 74-year-old woman presents with a rash on her left forearm. She first noticed similar lesions on her right foot, which have now resolved. She's been smoking 2 packs of cigarettes per day for 50 years. The patient has lost 20 kilograms over the last 4 months, and her stools are clay-colored. The physical exam reveals a woman with jaundice. Her forearm exhibits erythematous indurated cords. What is the most likely cause of this patient's skin findings? All right, this patient presents with erythematous indurated cords on her left forearm. She noticed similar lesions on her right foot, which have now resolved. Considering that she has a significant smoking history, weight loss, jaundice, and clay-colored stools, she most likely has adenocarcinoma of the pancreas. Migratory erythematous cords in the setting of pancreatic adenocarcinoma are most consistent with Trousseau syndrome, which is a superficial migratory thrombophlebitis. So, the most likely cause of this patient's skin findings is Trousseau syndrome. And that concludes our lecture on pancreatic cancer.